is separate circuit, separate kind of activity for walking. Okay? But forget that. Okay? We won't talk about that. There are also other rhythmic movements like scratching. Right? But let's see, like swimming, yeah. Running, all of them, okay? And in the brainstem, we have also different types of movements. For example, we have chewing. Chewing, eating, right? So, it's a type of rhythmic movement controlled by brainstem centers. We have breathing. You know that in the medulla and pons, we have centers related to respiration, right? We have also some other centers involved in the control of blood pressure, heart rate, everything. They are also motor functions, right? We have some other centers in this brainstem for some stereotype movement, like suckling. You know, in a baby, they can suckle the thumb. Or if you put something that tastes bad in their mouth, they put it away, right? I mean, in a newborn. We call these actually stereotype movement or smiling. These are types of movements. All of them are controlled by the brainstem. Eye movements are controlled by brainstem centers. But today, I don't want to talk about these. I want to mention postural movements, controlled by descending pathways from the brainstem. Right? So, reticular formation nuclei, we have medullar reticular nuclei, pontine reticular nuclei, vestibular nuclei. Right? Pontine reticular nuclei are the origin of pontine reticulospinal tract. Here. Medullary nuclei are the origin of the medullary reticulospinal tract. This one descends on the lateral funiculus. This one descends in ventral funiculus. Right? In the ventral funiculus, we also have vestibulospinal tract from the vestibular nuclei, from the lateral vestibular nuclei. Here. Right? And also we have medial vestibular nuclei that start from this one and this one. Right? You know them by the neuroanatomy. Right? So, the only thing that I want to repeat is that functionally, pontine reticulospinal tract sends excitatory signals to the axial muscles and proximal muscles of the limbs. Excitatory signal. But medullary reticulospinal tract sends inhibitory signals to the same muscles. We call these muscles anti-gravity muscles. Right? Anti-gravity muscles are axial muscles and proximals of the limbs, or proximal extensors of the limbs. And you know that these pathways first send the signals to the interneurons, and interneurons activate alpha neurons. Right? So, there is a balance between pontine reticulospinal tract and medullary reticulospinal. Pontine was excitatory, medullary was inhibitory, so their combined action on the muscle is something that happens during the normal state. Right? At the same time, we have vestibulospinal tract, which is similar to the pontine reticulospinal tract. They also, the fibers in this tract also activate anti-gravity muscles. Right? So anti-gravity muscles are contracted by pontine reticulospinal tract and lateral vestibulospinal tract. But they are inhibited by medullary reticulospinal tract. Another thing which is important for us. Pontine reticulospinal tract receives input neurons from vestibular nuclei, deep cerebellar nuclei, ascending sensory fibers from the spine. You should memorize these, we need them. Okay? Vestibular nuclei, deep cerebellar nuclei, and ascending sensory fibers activate pontine reticular nuclei. These neurons have also some intrinsic excitability. So they are intrinsically active and also receive excitatory signals from these centers. And they activate anti-gravity muscles. But medullary reticulospinal tract receives input from corticospinal tract, lumbosspinal tract or reticulus, and other pathways like from the basal ganglia. Okay? The medullary one inhibits the anti-gravity muscle. Okay. Lateral vestibulospinal tract receives input from the internal ear, vestibular nuclei, and vestibular apparatus. Right? So, it's involved in posture and balance. In the sense, it's laterally in the ventral funiculus, activate alpha and delta motor neurons, contract the truncal and proximal extensor muscles. They also inhibit flexor muscles. They are involved for postural adjustment after angular or linear acceleration. So acceleration activates vestibular apparatus. You will see this, or you will have this in the special senses, right? Then they send information to the vestibular nuclei. Vestibular nuclei cause vestibulospinal tract to be activated, and this tract contracts the muscle, so the muscle can correct the posture. Okay? So, we have another vestibulospinal tract called medial one. It starts from medial vestibular nucleus. It receives input from the semicircular canal, which is involved in circular acceleration. It sends bilaterally, but end in cervical and mid-thoracic levels. They cause adjustment in the head position. So when you are driving so fast, right, and then you turn, okay, there will be a deviation from the balance, right? This deviation is sensed by semicircular canals of the internal ear, activate the medial vestibular nucleus. The medial vestibular nucleus is the origin of the medial vestibulospinal tract. It causes contraction of the muscles in the neck, and you are turning this way, so you will change the position of your head in order to keep your balance. Okay? So head moves to keep your balance. Right? So this is mediated by medial vestibulospinal tract. So far we have seen the tracts that you have in the neuroanatomy, but with another view, physiological view, right? So now let's see some clinical aspects. Okay. If there is a cut in the spinal cord, you have seen the Brown sequence syndrome, right? But if the cut is complete, I mean, if there is a damage that disconnects the spinal cord, okay? What happens in the segments below the spinal cord? All of these tracts are lost, right? Reticular, vestibular, corticospinal, all of them are lost. So, segments located below the level of the cord will lose their inputs. Okay? So, the sensitivity of these neurons is regulated by the descending pathways. Now that all are lost. So the sensitivity is also lost. What's the reason? What's the result? All reflexes will be lost. So the stretch reflex is lost. Withdrawal reflex is lost. Also, the Golgi tendon organ reflex is lost. Blood pressure falls down because spinal cord is also the origin of the sympathetic fibers, right? And sympathetic nervous system is very important for the regulation of the blood vessels. When there is a cut, sympathetic nervous system loses its inputs, so the function is lost. Blood vessels are widened, so we will have vasodilation. Heart rate also decreases. So the result is loss of blood pressure, or a very abrupt and severe drop in blood pressure. We call this spinal shock. Okay, spinal shock. So normal activity of the cord neurons depend on tonic excitation by fibers from reticular spinal tract, vestibular spinal tract, cortical spinal tract. When they cut, all of them are lost. So all functions are gone actually. We call this spinal shock. What are the symptoms? A fall in the arterial blood pressure, all the spinal reflexes are blocked. The sacral reflexes for the control of bladder and colon, all are suppressed. At the same time, we have loss of movement, right? There is paralysis below the level of the cut. So voluntary movements are also lost. So this is the acute phase called spinal shock. But after a while, reflexes come back again. Okay? The sensitivity of the neurons increases again. So reflexes appear again. But this takes some time. And it depends on the species. I mean, in frog, spinal shock lasts for 1 or 2 minutes. In a mouse or in a cat, it may last for some hours. Right? Or some days maybe. In monkeys, spinal shock lasts for maybe 1 or 2 weeks. But in humans, it lasts for several months, maybe some years. Okay? So, after a while, reflexes come back again. And when they come back, they are exaggerated. Okay? So we have hyperreflexia. So maybe the touch of the skin causes withdrawal reflex. Okay? So withdrawal reflex normally happens by painful stimulation. But because they are very sensitized now, only touch of the skin may cause a reflex. Sometimes it's a good thing for the patient. You know, for example, the patient, when he or she is in the acute phase in the spinal shock, they cannot empty their bladder. Bladder is filled, but cannot be emptied because neurons are not working. Okay, usually there are some infections maybe. But after the hyperreflexia, the patient learns by touching the skin, he or she can empty the bladder. Okay, because reflexes are very sensitized now. And this is a good thing, maybe. So,
sir, if we cut the spinal cord, while reflexes are not there for some time, and after that there is hypersensitivity.
okay. So, I told you that the reflex depends on the sensory neurons that come to the spinal cord,
Yes.
right? And here we have a synapse on the postsynaptic neuron. For example, this one is alpha motor neuron, this one is 1A fiber. A. And they actually originate from the muscle and in the muscle, right? Here we have a synapse. This synapse is normally regulated by descending fibers. Okay, descending fibers regulate the sensitivity of the synapse. Now they are lost, so they lose their sensitivity. Synaptic activity is lost. After a while, the synapse actually regain its sensitivity. How? For example, we know that in the synapse we need postsynaptic receptors. Right? So, in normal state, maybe there are a standard number of these receptors. Now that there is spinal shock, gradually the number increases. So we will have more postsynaptic receptors than the normal state. So a very small release of the neurotransmitter can activate the postsynaptic receptor. This is one mechanism. Another mechanism. Maybe the axon terminal makes more than normal branches. Okay? So we call it sprouting. So sprouting happens at the end of this axon. So an action potential may release more neurotransmitters on the synapse than the normal state. So by synaptic plasticity, we call it synaptic plasticity, the sensitivity of this receptor of this synapse increases. So this way reflexes come back again. And because this state is going on and on and on, then the sensitivity of the reflex may go beyond the normal state. And they become more sensitized. Okay? So this is the explanation behind the reappearance of the reflex. Yeah?
Yes. Is it possible to cut spinal cord transaction without any spinal shock? For example, if you cut the unnecessary fibers.
Without the spinal shock?
Without spinal shock.
No. When you have cut, for sure you will have the spinal shock below the level of
Or
the
if we only cut the pain fibers.
Only cut the pain fibers? So sometimes this happens. For example, in surgical operation. So sometimes the patient may have a pain that cannot be treated by drugs, by medication. Okay? Maybe the patient has a cancer and he or she is going to be dead after 2 months maybe, or 3 months. So you expect that he will die after 3 months. Okay? And he has a severe pain that doesn't respond to morphine, doesn't respond to any painkiller. Okay? So, there is no other way for the treatment of the original disease. So, sometimes surgical operation can be administered in this patient. For example, we can cut spinothalamic tract. Okay? So we call this cordotomy. Okay? So spinal cord on the opposite side, in the anterolateral quadrant, is cut. So fibers are cut, the pain doesn't go upward anymore. Okay? So it causes temporary relief in this patient. Sometimes you can destroy some thalamic nuclei. Okay? It's possible. So in this condition, we won't have actually spinal shock. Okay? Another clinical symptom. Decerebral rigidity. Right? Yeah.